Welcome on behalf of BHC, California External Quality Review Organization, to our Demystifying Performance Improvement Project webinar. We are very pleased you stopped by to watch this video because there's a lot of misconception and a lot of fear about undertaking a performance improvement project. And our job is to make sure that it comes out as very easy for you. It will be very easy for you. There are certain steps you'll be following, as our experts will be telling you throughout this session. California External Quality Review Organization is a contractor for the state. The contract is held by Behavioral Health Concepts, which is a Missouri and California-based company. And the company has had much experience working with various types of external quality review organization and program evaluation type of responsibilities. So we are very pleased to be working as the external quality review organization for both mental health and substance abuse disorder services. California External Quality Review Organization reviews all the county mental health plans, called as the MHPs, and the drug medical organized delivery services plans. These are just starting up. The mental health plans have been in place for the last 20 years, since 1997. As part of this review, we follow Centers for Medicare and Medicaid Services, CMS protocols. CMS protocols have 7 different protocols, and these protocols are generally followed by most EQROs around the country. In California, protocol number 1, which is compliance services, those are all run by the state itself. We only do the rest of them, and one of the major ones of them is reviewing the performance improvement projects. And in doing that, what we do is really we look at whether those performance improvement projects are actually trying to improve the county's performance in delivering mental health services or drug medical services. Why is this very important? It's very important because few of our mandates include measuring that the plans are providing services with right kind of access to services, timeliness to services, and quality of care, and that the outcomes show that all those efforts are actually in play, actually working out. So given that the performance improvement projects become a very important part of the entire service delivery system, it's been very common in managed care plans for a long time, and it's kind of new for the county plans, but mental health side has been doing it for the last 20 years, as I said, with some difficulties, and that's why we have been doing a lot of this kind of workshops and other things, and this time we're thinking maybe all these basics can be in a YouTube video that you're enjoying. So with that, I think our experts should take over, and they have a lot of different insight to share with you, and I hope you'll enjoy this video and use it to improve services in your county. Thank you.
Welcome. My name is Rama Khalsa. I'm the director of the DMC EQRO, and this is the first in 5 video recordings we are going to do on performance improvement projects. We're very excited about being able to do these and upload them to YouTube so that you will be able to share them with your staff, and as staff turnover or new people need to be trained, you'll be able to record them. Also, the documents, the PowerPoint and the tool that we'll be referencing are attached to the video, and you can download the whole thing and be able to keep it at your county level and be able to share it. So we're very excited about being able to share this new format with you, and we'll be continuing to be resources for you throughout this rollout of the DMC ODS waiver. One of the things you do need to know is that we will also be welcoming draft conceptual PIPs as plans are approved, so that we can help you early in the process be able to save time and resources by refining your concepts and refining your PIPs, and be able to get them in a really good place well before your first reviews. And so with that, I'd like to introduce our BHC expert on performance improvement projects, Amy McCurry Schwartz, who'll be walking us through the PowerPoint. And at the end, I'll be playing the audience role, since we did this presentation yesterday in Los Angeles. And I'll ask some of the questions that the county participants had related to the conceptual PIPs. Thank you, and here's Amy.
Hi, my name, as Rama said, is Amy McCurry Schwartz, and I am a consultant to the California EQRO. I will be going through the Performance Improvement Projects 101 for Drug Medi-Cal, Bringing Ideas to Successful PIP Concept, PowerPoint. In addition to that, you will have in your tools a submission tool for how you would complete a conceptual PIP. The information we'll request, and I will be going back and forth between those two documents, and I'll let you know when I'm moving from one document to the other. The first thing I wanted to do was go through a little background on performance improvement projects, or PIPs as we will refer to them throughout this video. The purpose of a PIP is to assess and improve processes and outcomes of the substance use disorder continuum of care. Some of you may be wondering, how is a PIP different from a performance measure? A PIP focuses on program improvement, and a performance measure reflects the current performance of a measure that you may have within your program. There is a requirement for DMC programs to do both clinical and non-clinical PIPs. This requirement comes from the federal regulatory definition of a PIP. In 42 CFR, PIPs are defined as having focus on clinical and non-clinical areas. Clinical PIPs might target things like prevention and care of acute and chronic SUD conditions, including relapse, high volumes of services, such as 180 days or more of residential care in a year, high-risk procedures, or reducing clients that leave residential detox and not continue treatment. Non-clinical PIPs might target things like coordination of care across the SUD continuum, or with physical health and other treatment or support resources. They could also include appeals, grievances, or other processes of your organization, timely access to assessment and treatment, client services, and their experience with care. All of the information that we're discussing in today's presentation can be found in the Mandatory Protocol for External Quality Review, Validating Performance Improvement Projects, or PIPs. This particular document can be found at www.caleqro.com. In the CMS protocol, Validating Performance Improvement Projects, there are 10 protocol validation activities. We will go through each of these protocol steps individually throughout this presentation. Step 1, identifying potential study topics. Look for topics that impact a significant portion of clients. Get client input when possible. Data on a topic or approach could be very valuable with client input. Look for topics that have a potentially significant impact on client SUD recovery, functional status, or satisfaction. And always consider high volume or high risk conditions of the population that you serve. When you're identifying study topics, be sure to look for data sources that could help. Medi-Cal Eligibility Database, the DMC Encounter Claims Data, DMC Performance on Standardized Measures on Cal-OLMS is also available by program. Other sources of data could include external data from Medicaid fee-for-service, other health plans, local or national health reports, and research review of improvement efforts in this area. We caution you when you're looking at information from outside resources to be sure that this data has a direct correlation to the DMC ODS population. In other words, be sure that this particular information relates to your county. If you tell us that youth in the nation are likely to have used drugs in a percentage of 35% or something, be sure that you show us how that correlates to your specific county. Another area of data would be special studies that examine your study question itself. Now I would like to direct your attention to the PIP submission tool. So on page 2 of the submission tool, you'll see step 1, select and describe the study topic. Here we want you to assemble a multifunctional team including clinical staff, consumers, contract providers, and others as appropriate. Be sure to include a description of the stakeholders that are involved in developing and implementing the PIP. Describe their roles and how they were selected to participate. Then define the problem. The problem to be addressed should be clearly stated. What's the problem you're trying to solve? How does this relate to treatment or care impacting your system? How did this come to your attention? What data have you reviewed that suggests the issue is indeed a problem for your DMC? Describe any benchmarks that you may wish to achieve. Your study topic narrative will need to address what is the overarching goal of the PIP? How will the PIP be used to improve processes or outcomes of care provided by the DMC providers? The study topic narrative should clearly demonstrate how the identified study topic is relevant to the client population who are the target of the improvement project, and how the interventions have the potential to impact substance use patterns, functional status, or satisfaction of the clients being served. Now let's move to step 2, define the study question. Remember when defining the study question to make the question obvious, to make the question simple. Above all, be sure your question is answerable with the data and the design that you are considering. Remember, 1 + 1 = 2. State the question in a way that supports your ability to determine whether the intervention has a measurable improvement impact for a clearly defined population. Start small and simple. Incremental approaches are easier to manage. And then, if you are successful, you can bring your project to scale. Define the study question. Number 1, what's the problem? Try to define the problem as a system issue, clinical or process-oriented, that relates to individual clients' treatment, outcomes, or satisfaction. If the problem you're addressing is no-show rates, you as the MHP may see this problem as fiscal, efficiency, and inconvenience, a provider communication or partnership with the client. But you need to look at the problem, how it affects the client, and frame your question around how you will improve the experience or the outcome for the client. Study questions are measurable and manageable issues that reflect a goal of a PIP. The goal is to assess and improve processes and outcomes. It's important for you, the client, and to the provision of quality substance use healthcare services to remember this goal. Don't write a question that asks, will providing pre-appointment reminder calls for all assessment appointments reduce the DMC's costs? Or, will providing training to all frontline staff get them to enter the appointments in a more timely manner into the electronic health record? Instead, think or ask, what's keeping clients from their appointments? What are the barriers for them to coming to the assessment appointment? Is it transportation? Time off work or school during clinic hours? Childcare? Remembering because it was too far from the request when the appointment was actually scheduled? Frame the PIP around these barriers. Provide interventions that mitigate these barriers for the client. Beware of vague or implied study questions. An example of an implied study question would be, is a male intervention reminder adequate to improve SUD medication adherence over time? Or, can we evaluate the use of appointment reminders? Make your questions clearer, such as the example on page 23. Will providing educational materials to doctors, counselors, and clients increase the number and percentage of clients who participate in medication-assisted treatment and decrease the number and percentage of clients who use counseling service without MAT supports. Remember, it's even better if you add a factor by which you wish to increase. 10%, 5%. So will reducing the number or incidence of multiple intake assessment appointments prior to the first treatment session increase the number of clients successfully engaging in treatment? Defining the study question is a critical step because it sets the framework for data collection and analysis of the results. Take your time and develop a strong study question. Consult with your assigned EQRO staff to help refine the question and bring it to concept. Now I'll refer back to the PIP submission tool. In step 2, define and include the study question. The study question should be stated in a clear and concise, answerable format and should identify the focus of the PIP. The study question establishes the framework for your goals, measurement, and evaluation of the study. Remember, technical assistance is available to help with this formulation as needed. Step 3. Use a representative and generalizable study population. Each PIP must potentially represent the entire SUD Medi-Cal population to which the study indicators apply. For example, a youth question might be studied only at one program or one clinic, but have potential to improve all such programs or all clinics. The DMC must decide whether to review data for the entire population or a single program or unit, or a set of that population. Remember, it's good to start small and incrementally bring to scale if the intervention works. There are many reasons to use a unit, set, or single program when designing your PIP. You may have limited resources to analyze the data. The intervention and data collection could also be very resource intensive, and you don't know yet if it will be effective. So whether to spend your resources on that particular project is something you could answer from beginning small. On slide 31, you'll see a population example. Look at all DMC clients ages 0 to 18 years who may have a primary diagnosis or a secondary diagnosis of a specific disease or disorder, as identified through claims data. This is a way to narrow your population and consider using data for a subset of the entire DMC population. On the submission tool in step 3, you will see instructions to clearly identify the SUD client population that is included in this study. Include an explanation of how the Performance Improvement Project will address the entire population or that specific group. If the study pertains to an identified sector of the DMC client population, how you included all those members will need to be detailed in step 3 in the PIP submission tool. This step can include demographic information such as age, ethnic group, spoken language, specific diagnosis or treatment. Other study sources such as pharmacy data may be utilized to identify clients who you will target in the study. Depending on the focus of the improvement, different data sets as well as research studies will also apply. Step 4, select the study indicator. A study indicator is a quantitative or qualitative characteristic reflecting a discrete event or continuous status to be measured. A study indicator is used to track performance and improvement over time. A study indicator should be objective and clearly defined. The indicator must be measurable. Do you have the necessary data to measure the indicator, or can you get it? Client input is recommended when selecting your study indicators. Many counties would utilize their client advisory board for this particular function. It is important when selecting a study indicator to use an existing indicator whenever possible. Generally accepted in the SUD clinical guidelines may be indicators from ASAM, SAMHSA, HEDIS, or other sources. Use of an existing relevant SUD best practice or guideline to develop your study indicators is a way to track improvements or change. Don't reinvent the wheel. In slide 36, you can see some examples of study indicators. Clients enrolled in SUD outpatient clinics with 4 visits within 30 days of an initial assessment would be an access and engagement indicator. The percentage of clients who complete residential detox and transition to the next level of care within 14 days is a transition in care indicator. Additional study indicator examples would include percentage of methadone clients with 9 months or more of regular treatment visits, or the percentage of current methadone clients able to work at least 20 hours per week. The difference between these 2 study indicators is that the first is a process measure and the second is an outcome measure. You're seeing in the second example an improved functioning indicator. In the submission tool, on step 4, selecting the indicators, the PIP submission tool asks you to report a description of the indicator, to include the numerator and denominator, and the denominator would be the number of people in your population. The numerator would be the number of people who are affected by your indicator. The baseline for each performance indicator should be included in step 4, and your performance goal. There is a table included in the PIP submission tool which will guide you in how to complete this step. Step 5 begins on page 40 of your slide deck, the use of sound sampling techniques. Proper sampling techniques are necessary to provide valid and reliable information on the quality of the care provided. The Cal EQRO cautions you that true statistically valid sampling is difficult. Since this presentation is geared toward concept PIPs for DMCs, at this point we're considering that you should use a representative clinic or program that is small and built out unless you have statistical and data capacity for statistical significance sampling. I will briefly go through the types of sampling that could be used. Probability sampling, such as simple random sampling, and non-probability sampling, which is based on choice, not chance. A probability sample would include a study of how many clients received a client satisfaction survey after completion of a level of care during a specific year by random sampling 100 of the 1,000 studies in the DMC population. A non-probability sample would be a study of the performance of an outpatient clinic by sampling all the clients that were seen on a specific day. Probability sampling would be accurate sampling. Non-probability sampling would not. In the PIP submission tool, there's a section on sampling. In step 5 of the tool, you're asked to describe your sampling methods, if applicable. This would include identifying the number of enrollees in your sampling frame, the number of the sample, and the number of participants. Moving on to step 6, reliably collect data. The data you collect must be valid and reliable. Validated is an indication of accuracy. The data measures what is intended to be measured, and no other data is mixed in. Be sure you're comparing apples to apples. And even further than that, be sure you're comparing the right kind of apples to apples. Some examples of how to reliably collect data or issues that you may have when collecting data could include attendance. Attendance may be a valid measure of engagement, but is not necessarily a valid measure of satisfaction with the program. One example of an issue with reliably collecting data came to us from one of our counties. A client satisfaction survey in itself was reliable, but they discovered that because it wasn't anonymous, they had asked folks to sign the survey, the response was biased, and that in itself reduced the reliability. Reliable, the indication of repeatability of collection method and source. For something to be reliable, be sure you're collecting it the same way over and over again. Do it and then do it again. Be sure to develop a data collection plan. Clearly identify the data which you will be collecting. Identify the sources and how and when baseline and repeat indicators will be collected. Set a date. If you plan to collect data on the 15th of each month, collect data on the 15th of each month. Consider the way that your data will be impacted if you deviate from your data collection plan. Specify who will collect your data. Be sure to use personnel that have the skills that are needed to abstract the data. In contrast, trained assistants or medical record clerks could be used to abstract data from medical records if you're only looking for the presence of a diagnostic test or an assessment or a report. Can they check a box to say it is present or it is not present? In that instance, you can use staff who are not counselors to extract the information. Identify the data collection instruments that you will use. Is it a tally sheet? An Excel spreadsheet? Will you be able to collect the information in your electronic health record? Be sure it's collected the same way by the same type of staff each time. Train your staff to collect the data in the way that you need it to produce reliable data for your evaluation of your performance improvement project. On the PIP submission tool, you will be asked to complete in step 6 information about how you plan to collect data and what you plan to do with the results of that data. In step 6, be sure to describe the data to be collected, the method you will use to collect it, the staff who will collect that data, the instruments they will use, and be sure to include a prospective data analysis plan. Include what you will do if the results that you collect are different from what you planned them to be. Step 7, analyze data and interpret study results. Use your data analysis plan to guide you in this step. Be sure to measure how the identified group or program performed on your selected indicators. If you have baseline data for indicators, be sure to include periodic tracking of a change in the indicators over a planned time period. Valid interpretations or analysis of data occur when the analysis is conducted according to your plan, when the results present numerical data that is accurate, clear, and easily understood. Valid interpretations occur when analysis addresses the comparability of an initial baseline and repeat measures, including the factors that threaten validity. In other words, if you collect data in a certain manner during the baseline, be sure to repeat that data collection during your additional measurement periods. If this is impossible due to changes in your system or other factors that influence the data collection, be sure to include those factors as they threaten the validity of your data. Be sure to draw a conclusion as to the success of the PIP, and any planned follow-up activities should be described so that you can refine your design and the PIP could be extended or continued. Referring to step 7 in the PIP submission tool, describe each intervention and identify any barriers to the intervention. Identify the corresponding indicator that measures the performance of the interventions, and be sure to maintain integrity and measurability of each of the interventions. We have provided an example table that you can fill in, which will include all the relevant information that you need for step 7. Step 8, implementing interventions and improvement strategies. Remember, your interventions should relate to the causes and barriers that you identified through your data analysis. This is where your PIP committee and clients' input would be beneficial. If we go back to the issue that we discussed, no-show rates, the barrier that we identified was transportation. What could be your intervention? Bus and taxi vouchers, gas reimbursement, How can you get people to their appointments? If the barrier we identified is time off from school or work during clinic hours, can you offer after-hours SUD clinics? Can you offer a home visit or another location within the community where many of your clients live or work? This would be exceptionally relevant if you're dealing with something like injections or therapy. If the barrier identified is childcare during the appointment time, can you arrange for childcare at your clinic, or can you provide a voucher for childcare at a community center or a YMCA? Remember that your interventions should be culturally and linguistically appropriate, and they should ultimately be implementable system-wide. If you start small, be sure that that intervention can be repeated when you expand your project. Additionally, interventions should not be one-time efforts. Remember, if you set out to improve something and your intervention is to provide childcare, you can't provide childcare just one time. It'll be something you need to repeat. An improvement strategy is an intervention that's designed to change behavior, either at an institutional level, the practitioner level, or the client level. As you all know, a change in behavior is not something you can effectuate with one-time efforts. Real, sustained improvement results from a continuous cycle of measuring your performance and implementing system-wide improvements. Your design and your implementation may change. Repetition is the key to sustained improvement. In step 8 of the submission tool, data analysis and interpretation of study results, you will be asked to include the data analysis process. Be sure to answer whether it occurred as you planned. You will also be asked to include whether your results triggered any modifications to your project or to the interventions. Did you discover something that you weren't planning on? What did you do to modify the project when that was discovered? Are there any follow-up activities planned? Did the results of your PIP trigger something new, a new issue that you've identified? What do you plan to do about it? Be sure to review results in adherence to any statistical analysis techniques. Were your results statistically significant? Are you able to demonstrate a true improvement or decrease as the result of your interventions? There's a table provided in this section of the submission tool to guide you with the information that you need in order to successfully submit the information to Cal EQRO. Step 9, the plan for real improvement. When change in performance occurs, you need to determine whether the change is real and whether or not it's attributable to an event unrelated to your interventions, or was it just random chance? An example of an event that may be unrelated to your intervention but may affect improvement in your program would be one that we received from LA County. They had an initiative to improve stable housing in their homeless community. And at the same time that they were implementing the interventions to improve that particular issue, LA County passed an initiative regarding homeless housing. Again, we stress to be sure that your results of the intervention are statistically significant. Consultation is available from the EQRO on how you can measure statistical significance of your interventions. In other words, if your goal was 2% improvement, out of a population of 100, only 2 people improved. Was that actually a statistically significant improvement? Be sure to contact your EQRO reviewer if you need some assistance in this area. On the CalECRO submission tool, Step 9, assessing whether improvement is real improvement, requires you to describe the issues associated with your data analysis. Did the data cycle clearly identify when the measurement would occur? Could there have been an outside influence on the measurement? Were results statistically significant? What factors influence the comparability of your initial assessment and your final assessment? Be sure to include your idea of to what extent the PIP was successful and how did the interventions that you applied contribute to this success. In Step 9, you also want to include information about how you plan to refine the PIP. Will this PIP become part of your day-to-day operation? Or do you have a new intervention that you wish to try to continue the PIP? It is essential to determine whether or not the reported change is real change. How did you validate that the same methodology was used in the initial and the final assessment? Was there documented quantitative improvement in the process or outcomes of care? Was the improvement sustained throughout repeat measurements over comparable time periods? Or when you added new sites or new populations to your PIP? And finally, Step 10, achieving sustained improvement. If real change has occurred, the project should be able to achieve sustained improvement. Sustained improvement is demonstrated through repeat measurements over time. Now, your improvements can be expanded to other clinics or other programs with data monitoring to ensure that they're working there as well. Please reference the CMS protocols, information and location included on slide 66 of this presentation. Now Rama will repeat some of the questions we received during our webinar in Los Angeles.
Okay, so the first question was, if we do PIPs that cover both mental health and substance abuse, can we do 3 PIPs instead of 4? And we have asked for a clarification of this of DHCS, and they haven't responded yet as to whether or not we will be able to do 3 versus 4 performance improvement projects, but we will be continuing to follow up to get that clarification. Some of the counties are already doing some dual diagnosis performance improvement projects. And given that this is a waiver for the DMC ODS, we're anticipating it's likely they will want at least 2 of the 3 to be on the drug medical area, at least for a few years, because that's the new area being tested. But we're not sure. We're going to wait for that clarification. So one of the first questions that came up in Los Angeles was, how do you decide exactly what is a clinical and non-clinical PIP? There was still confusion about that. What is the key factor that influences what it is, since they all have to improve client outcomes and they all have to benefit clients? There was still some vagueness there. And so, Amy, maybe you could clarify what some of those key issues are.
I will, and I would like to be sure to let you all know that the differentiation between a clinical and a non-clinical PIP is something that is difficult for everyone and is something that continues to be an issue after the many years that I have been doing this. But one of the things that folks should concentrate on is the intervention that they are employing. All PIPs have to have a clinical impact, meaning that they should affect clients and the improvement in an impact for those clients. If satisfaction is something you're measuring, you have to measure satisfaction along with a clinical impact. But an intervention may determine whether or not a PIP is clinical versus non-clinical. if your intervention is to use, let's use our no-show example. If your intervention is to call folks 2 days before their appointment, send a text 1 day before their appointment to get them to show up for the appointment, then that particular intervention would be non-clinical. And you could see that how easily that would be a non-clinical PIP. Remember, the intervention is the key. However, it's much easier for us to take a clinical PIP, something with clinical interventions, and turn it into a non-clinical PIP than it is to take a non-clinical PIP and make it clinical. So when you're thinking about putting your PIPs together, I would think about, what are the issues for my county? I would think about, how can I address those issues? And then don't think about whether or not this fits into the non-clinical PIP and this fits into a clinical PIP. Just identify 2 issues for you, and then we can work with you as the reviewers to mold those PIPs into clinical versus non-clinical PIPs. I think folks sometimes get too caught up in that, and we would much rather people be identifying issues that they want to tackle than worrying about whether or not they're going to have a non-clinical or a clinical focus. But I would also refer you back to that CMS Protocol 3, where there are included some more examples about what a non-clinical or a clinical PIP would include.
So one thing we did mention in the slides was medication-assisted treatment. And that would be potentially a very good clinical PIP, because the intervention was a new medication treatment being introduced into therapy for the client, which is one of the new evidence-based treatments that has been shown to have a very strong link to recovery and improved outcomes in substance use disorders. So you want to look at the literature when you do your initial PIP concept. And one of the questions was, how do I look at making my study question as relevant as possible to outcomes? And what if I don't have that much local data? Can I use national data? And what do I need to think about if I use a national study? And I think you had some thoughts about that.
Yeah, I think when you use a national study, you need to just be sure that you can collect information locally. Don't just tell us that nationally 35% of youth are using opioids. Be sure to collect that information. Look for sources in your local community to show that is an issue in your local community. Maybe a good source of that information would be the school surveys that we've discussed. There, in the state of California, 7th, 9th, and 11th graders complete a confidential drug use survey. That would be where you could tell whether the problem of opioid use was actually affecting your community. I'm told the data in that particular survey is very useful, considering that it is a confidential survey. So I think you can use the national, international data to identify issues, but you need to be sure you can collect the data locally to prove that your intervention improved that in your community. So
there's also SAMHSA conducts a national household survey that's going on right now, and the results will be available in January 2017. Each county is eligible to get their own data that is collected. It's a confidential phone survey, I believe, and the health officer for the county must request it, but it would give you another source of county-specific data, and that includes adults and older adults. So that's another thing that would let you have some more local data that you could use to look at prevalence of drug use and other things that might link to your studies. So another question was, can you give an example of how consumers might be used as part of the formulation of your study questions and your interventions?
Right. And in this discussion, we talked a little bit about how consumers could serve on an actual committee,
Yeah.
in-person committee, or how you could obtain information from consumers in a survey type of format. You might include at the end of each of a therapy session a question or two that, although not scientific, would lead you in a direction of how they may have felt about the services they received and what were some issues that they had getting to their appointment. If you are tackling something such as no-show rates or wanting to set up an after-hours clinic and find out when these things might be useful for your clients, you might want to follow up with the folks who you've had issues with and ask them what were the issues and why weren't you there? Why weren't you able to come to our appointment? But I think the use of clients, it doesn't have to be, if you do decide to use your clients on a committee, it's not expected that the clients attend every committee meeting. You may have a committee work group where you're actually working on the design of your PIP, and it wouldn't be practical or necessary that a client be available at that particular meeting. But what is expected is that you use their input to design the way that you plan to set up your interventions so that you're at least identifying the issues that they would have. And how you choose to use those clients is up to you, but it is necessary that you do look for their input.
Another question was related to adult drug court and whether it would be possible to use the intervention of Vivitrol, medication-assisted treatment that requires monthly shots, for evaluating retention in drug court. One of the counties had seen a real reduction in people staying in the drug court treatment programs. They were dropping out, they were getting rearrested, and they were thinking this might be an improvement with a new treatment, and could they do it in one drug court or they had 7 drug courts, and how might they approach a problem like that?
And I think that in this particular conversation, we discussed their reluctance to only employ this in one drug court because they didn't want to make something available to one and feel like they had excluded the others, and it was something they would need to necessarily roll out to all of them at once. And I think in the discussion that we had, we talked about how there were other things they probably needed to identify.
Right.
That they had an intervention they thought would improve their outcomes and their retention, but they hadn't really done that first step of talking to the stakeholders. They hadn't really done that step of and when we talked about stakeholders, not only clients in this instance, but also including probation and parole. And in this particular instance with the drug court, we discussed with them how they needed to include stakeholders, not just clients, but also probation and parole, judges, the folks who are working in the drug court, because there may be some issues that they haven't identified that the Vivitrol would not solve.
Right.
One of the things we discussed was what if they aren't returning because of the experience or the customer service that they receive. And of course, they wouldn't be able to fix that with Vivitrol. So although they had identified an intervention they were interested in using, we had encouraged them to consider the fact that there may be other things that the performance improvement project should include and other factors that may be keeping folks from being retained. We also ask them to consider using people who had graduated from their program, not necessarily using current clients, but people who had completed the program, people who could tell them maybe why they completed the program, and then also maybe some of the barriers to completion.
Right, elements of success and support as well as barriers. Because many of the clients that start to try to work, and the hours of the court aren't always convenient for people who work. And so there were a whole bunch of potential issues, as well as the medication-assisted treatment, which could reduce cravings and impulses to return to drug use, that could help make drug court participation more successful.
And I also remember this example kind of wove into the localized data issue as well.
Yeah.
Because when the example was brought forward, the question was asked, what type of data do you have to show that your retention has decreased? And they really didn't have much of a measurement of that. They knew that at some point in time, more people were graduating or retaining in the program,
Right.
and now less people were.
Right.
But they really didn't have an analysis of whether that occurred at one drug court versus another drug court, or whether they could pinpoint maybe some issues in that way. So we also encourage them to go back and look at that particular localized data and come up with some other areas they might focus on.
Yes, and I think this is one of the things that's often skipped or not done enough, is looking at your own data for the baseline to know enough about what's going on to formulate as clearly those key study questions, because the issue of whether it was opiates or not, which was another theory, that it was the opiates causing the dropouts. They didn't have any data yet on that either.
That's true.
And so you really want to have dug a little into your data to do that research before you put together your interventions and put together your indicators and other things.
And this is a real caution, and something we've seen as
Yeah.
we've been doing this on the mental health side, is a lot of times people do have an idea of what the program is that they want to put together, but they haven't done that data collection, they haven't done that background,
Right.
and they jump into an intervention that may or may not affect the problem
Right.
because they haven't identified what the true issues are. So we would caution folks on the DMC side, as you're putting these concept PIPs together, to contact your EQRO reviewer. RAMA can put you in contact with who is responsible for your particular geographical area, and discuss with them your ideas so that they can help you kind of flush out some of these things, and you are not jumping to and putting in an intervention because we hear it's the next best thing.
Yes, and I think that's a common experience based on just reading articles. There's so much publicity these days about different drug trends to want to test them, but you really do need to see, are they a good match for what's going on in your county?
And I think this brings up a good question that I had forgotten that was in the room yesterday. The difference between a research study and a performance improvement project.
Right.
And the fact that in a research study you're testing a hypothesis. You're measuring whether or not the intervention you want to do works.
Right.
And the goal of the performance improvement project is to know the data and to do interventions that you try to move an outcome instead of determining the effectiveness of the interventions. So in a performance improvement project, you may be employing interventions that have been tested somewhere else already.
Right.
And you're seeing if it works with your population. So the difference there between the study, a research study, and the performance improvement project.
Another question was, when is it appropriate to extend for a second year? What happens, and how would you think about that as part of your transition of your PIP?
Right, and one of the things that we are steadfast on in continuing a PIP for an additional year is that you need to be able to implement a new intervention.
Right.
So you need to have a new idea that you can measure, a new intervention that you'll be applying to the population. That's the number one criteria. In addition to that, you may decide if you're phasing a program in, that you may pilot it in one clinic for a few months and move to another clinic. And although ideally the interventions that you employ will work exactly the same, the likelihood of that may not be. So that would be maybe an incident when you would be able to extend a PIP.
Mm-hmm. And there was a question about when do PIPs actually start? How many steps of the process till they technically turn on?
Right. That was a good question, and that's one that we get a lot. And we are encouraging in this particular, in the DMC side, we are looking for people to come up with a concept. We're not expecting people to come up with a full-blown, we're ready to go PIP. But a performance improvement project would be considered active as soon as they have employed an intervention. So as soon as they have put out their intervention and they've started measuring the effectiveness of that intervention, a performance improvement project would be active for this particular purpose.
And one of the questions is, when does that have to be in place? And that needs to be in place when we do our first review. And as we understand from the state, that will be a year after new services begin. So, for example, San Mateo just brought their contract to their Board of Supervisors. They are now active. So a year from now, San Mateo will have its first formal review, and they will have to have an active PIP. But in the meantime, we're trying to work with people to do the concepts and have everything copacetic and in great shape, so that by the time we show up, there shouldn't be any problems with the PIPs they've implemented. So that is one of the supports we're trying to do. And one of the questions is, do we have to do it early? No, you don't have to, but it makes it easier and less stressful to have it done in advance and have your concept flushed out and have that technical support.
Yeah, the worst thing would be if someone started something and ended up way down the wrong path, and we had to instruct them that it was not going to rise to the level of a performance improvement project, and they had to start over. So encouragement is very strong that they consult the EQRO and when developing these concept PIPs.
Yes, it really does help. And so step 1 through, I believe it's 6, are basically the concept part. And then you move into more of the evaluation, and you've been in the process. So that would be where we would offer a lot of technical support, even flushing out the study question, which often the study questions kind of aren't as clear as the 1 + 1 = 2, and we want to be sure they're really good and simple and easy to understand. So I think that brings us to the end of our questions from Los Angeles. So thank you so much for spending the time with us to watch this introductory video on our performance improvement projects for the DMC. We'll be having a phase 2 video that will use some real examples that relate to different drug and alcohol problems. And we'll be sharing those conceptual PIPs with you and walking through why they are good conceptual PIPs, so that you'll have something to work with if you're just really not sure where to begin. And we do have some substance use content experts who will join us and share some of their thoughts as well. So thank you so much, and we are available at the EQRO to help with looking at any of your ideas or designs or questions on any of these phases. And I'd like to thank Amy for coming up from Missouri to help us. with this presentation.